Well, good afternoon. Welcome back from lunch. We are starting off our afternoon with the panel Fall and Winter Respiratory Diseases, the vaccination season ahead. As we plan for the upcoming fall and winter virus season, it's important to apply lessons from previous seasons and thoughtfully explore solutions to reduce the burden of COVID-19, flu, pneumococcal disease, and RSV, and how they affect the U.S. healthcare system, the negative impacts on the economy, and additional stresses for individuals and family during this respiratory disease season. This session, we will hear from the following speakers. First will be Dr. Emily Brunson, who's a professor in the Department of Anthropology and the Associate Dean for Promotion in the College of Liberal Arts at Texas State University. Next, we will hear from Molly Howell, who's the Immunization Director at the North Dakota Department of Health and an active member of the Association of Immunization Managers and the National Vaccine Advisory Committee. Then you will hear from me. You all know who I am. And finally, we'll hear from Dr. Brendan Jackson, who's a Senior Advisor for Readiness and Response and to the 2024 Influenza H5N1 response at the CDC National Center for Immunization and Respiratory Diseases. Dr. Brunson, your slides are up. You have the floor.
Excellent. Thank you very much, Dr. Hopkins. It's a pleasure to be with you today. My name, once again, is Emily Brunson. I'm a professor of anthropology at Texas State University. I recently was one of the co-leads of CommuniVax, and I'm currently a committee member for the National Academy's Societal Experts Action Network, or SHAN. Today, I'd like to share with you the content of one of SHAN's recent reports that dealt with promoting uptake of COVID-19 influenza and RSV vaccines. So next slide, please. Fall 2024 will be the second year that vaccines for 3 respiratory diseases, COVID-19, flu, and RSV, will be available simultaneously. If taken, these vaccines can mitigate increases in cases, hospitalizations, and deaths that could strain the healthcare system, negatively impact the economy, and add hardship to families. Okay, can you press enter again, please? The critical issue we're facing in the upcoming year isn't one of technology. It's actually one of people. Uptake, specifically individuals receiving vaccines, is not guaranteed. And in fact, data from last year suggests that recent uptake was far from optimal. According to data from the CDC, just under half of US adults received the flu vaccines. Uptake rates for COVID-19 boosters and RSV vaccines were both under 25%. And enter again. So under these circumstances, what can be done? How can we collectively improve respiratory vaccine uptake? The answer isn't entirely simple, and I will clarify right now that there is no easy solution or silver bullet, but general strategies do exist, as do specific approaches for the different vaccines. Next slide, please. To begin, I want to discuss the issue of access. Uptake is a combination of choice and access. In developed countries, choice, or in other words, people's decisions to take or not take a vaccine, is often the central concern. But access plays a significant role in vaccine uptake, even in the US. Access can include literal access to vaccines. For example, is there a vaccine location close by? Are there transportations to get options to get there? Other aspects of access are more subtle, but not less important. Are vaccines affordable? Do people have the ability to take time off work to be vaccinated? Do people have the ability to manage family responsibilities like elder care or child care to have time to be able to get vaccines? Are vaccines available in places where people feel safe? For example, places where they will not be scrutinized for things like citizenship status. And is information about vaccines, including the location and times of vaccination clinics, available in multiple languages and all of the different languages that people in a local area will speak? So next slide, please. To address access issues, Sean suggests 3 general strategies. First is ensuring equity in access. This involves addressing structural barriers such as difficulties to getting to vaccination sites or paying for vaccines. Successful efforts that have worked in the past to address people's abilities to access vaccines have been, for example, providing vaccines in rural areas that have few or no public transportation options via mobile clinics. In other words, taking vaccines to the people in those situations. Another option for 2 is to increase community demand. This is especially important within marginalized populations that may have trust issues or lack of trust in the healthcare system generally, in public health or in the pharmaceutical industry. Community demand in these situations can be fostered through culturally sensitive, community-based campaigns and educational interventions, especially when they're utilized or delivered by trusted community leaders. And third, Sean recommends improving provider and system-based interventions. This is specifically for people who are already involved with the healthcare system. It involves healthcare providers and systems using multifaceted interventions such as patient reminders, provider education, the use of electronic health records, and implementation of standard orders in order to encourage patients to be vaccinated and also explain to them how they can receive the needed vaccines. Okay, next slide, please. So turning to choice, this is also important to consider in terms of vaccine uptake. People's choices are shaped by a variety of factors, including their past experiences with healthcare and vaccines, their thoughts on the US healthcare system, their political views, and other factors. In considering choice, though, it's important to remember, if you can hit enter again for me, please, that people do not make their decisions in a vacuum. They make them in consultation with others, including the people they know, their spouses or partners, extended family members, friends, coworkers, and others, and with the cultural groups of which they're part, their communities, their churches, their social media groups, and so on. In terms of aspects of choice to consider, when promoting uptake of respiratory vaccines, there are 2 primary issues: public awareness and understanding of the different vaccines. And this is going to be especially important for the newer COVID-19 boosters and RSV vaccines, and also individuals' motivations to get vaccinated. Next slide, please. To address access issues, Sean suggests 3 communication strategies. The first one is to communicate with transparency and openness. Public engagement is critical to building trust, and good engagement requires dialogue. This involves truly listening to the public's concerns and then responding with empathy. It also requires transparency. For COVID-19, flu, and RSV vaccines, this will involve clear communication about the vaccine development process, including any updates, changes in recommendations, or new findings, explaining what is known and what is not, and also clarifying how and when new information may come that could change recommendations. It's also critical to be clear on the what, the why, the when, and the who. For the what, this is going to be the importance of the vaccines, the risks of their associated diseases, and so on. The why is why people are being encouraged to be vaccinated. The when is the timing of vaccines, and the who is who the communication is geared to. In some cases, and for example, pregnant women and older adults, messaging may need to be adapted to address specific concerns of these groups. Second, Sean recommends using updated data to highlight susceptibility to infection. Individuals tend to abide by their prior decisions and this includes whether to get vaccinated or not. To get people to change their minds, and in this case, to get people to accept vaccines when they didn't last year, it requires presenting new information that highlights recent events and gives people the opportunity to reconsider their approaches given the changed environment. For the respiratory vaccines, this can include things like the correlation of the flu vaccine to the presently circulating flu strains, or the incidence of RSV among older adults in a particular area. Finally, Sean suggests using trusted messengers. Trusted messengers are individuals with pre-existing ties to communities who are looked to as sources for guidance, information, or support. These can be religious leaders, community organizers, healthcare providers, or others. When messages are shared through trusted messengers, their impact can be greatly enhanced. Next slide, please. Of course, the communication we're talking about is also not happening in a vacuum either. Social media use, and especially recent public health events and the increase in social media use that has occurred with them, have amplified mis and disinformation about vaccines. This is a complicated issue that requires much more time to discuss. But in a nutshell, public communications to address mis and disinformation, it should do a few things. It needs to provide accurate information and once again, acknowledge uncertainty, especially if there's an idea that recommendations may be changing, that needs to be clarified up front. Information needs to be presented from reliable sources, such as the CDC. Information needs to be provided quickly and widely, especially if it's new information or new recommendations. Different groups, and this can include providers' offices, local health departments, state health departments, and others, need to provide consistent, unified messages. And finally, communication needs to be optimized for internet searches. All of these can be complicated. The third and fourth items on this list can be particularly challenging, but they are essential. And to be done well, they require pre-planning among various organizations, especially at the local level. Okay, next slide. So we could spend more time discussing communication strategies for specific vaccines as well, but for time, what I did is I pulled out one recommendation for each that deserves particular attention. For the flu, one of the biggest public gripes about the flu vaccine can be summed up by the phrase, "I got the flu vaccine last year, and that was the first time in 20 years I got the flu." Specific emphasis is needed for at-risk groups, including older adults. Communication should also address how the vaccine matches with the current circulating flu strains. For COVID-19, concern about COVID-19 has waned. And the pandemic writ large and COVID-19 itself is now something that many people want to put completely behind them and not talk about anymore. Communication, therefore, needs to address why the vaccines and why booster doses are needed, and also how they will work given the current conditions of viral spread and also mutations. And finally, for RSV, the newness of the vaccine is critical. Communication needs to emphasize who the vaccine is for and what it can do, particularly building on information from last year's vaccination campaign. So that's it for my time, and so I will close now. Thank you once again for letting me join you today.
Thank you. Our next presenter is Molly Howell. Molly?
Thank you. Good afternoon. Excuse me. I'll be presenting on the behalf of the Association of Immunization Managers. Let's see. So just a little bit to start about AIM. AIM represents the 64 awardees that are federally funded. This includes the 50 states, 6 major cities, and 8 territories or federated states. AIM is a nonprofit organization that was established back in 1999 and is actually about to have its 25th anniversary later this year. And basically, AIM helps immunization managers from across the country work together to address immunization-related issues with the vision of a nation free of vaccine-preventable diseases across the lifespan. So what does an immunization program do, or what does an immunization manager do? So routine activities that we do every day is we try to strategize to increase immunization rates. We collect data and use data, usually through an immunization information system that helps us guide decisions, programmatic and implement programmatic activities. We conduct immunization education of healthcare providers, the public, stakeholders, immunization promotion and communication. We work on quality improvement activities with providers in our jurisdictions. We specifically respond to outbreaks and try to control outbreaks through vaccination. We establish partnerships with both traditional partners, as you would expect, pediatricians, family practice, but also non-traditional partners, community-based organizations, and more pharmacies are becoming a traditional partner that we work with. We work to serve underserved populations that maybe have lower rates of vaccination. And we implement the Vaccines for Children program, a federal entitlement program, which provides vaccines to children who are American Indian or Alaskan Native, uninsured, underinsured, or Medicaid eligible. So when a new vaccine or immunization becomes available, it's a lot more about than just the products available. So now everybody can get it. You have to actually work to make sure that people are able to access it and that they're aware of it and that they want it. And so some of the things that need to happen when we have a new product, such as with Nursivimab, let's say that we had last year, is we have to work to add that product to the immunization information system. And so every immunization has specific codes that have to be put in the IAS. And then we have to work with electronic medical records from all the providers that we work with to make sure that they're sending us that information so we're able to get that data. The product also has to be added to our VFC programs so that providers are able to order the vaccine for VFC eligible patients and plan for supply. Sometimes we'll be on allocations. We have to educate our partners and providers about what the recommendations are for the product, how the product should be stored and handled, and how they can order that product. And then often we end up working with insurers, including our Medicaid offices, to make sure that they're covering the product appropriately and that they've added it, and that providers will have access to payment for that product or the admin fee. And then, of course, create a plan to ensure access and equity. We want to make sure that the product is available throughout our jurisdiction and that we have VFC providers available who are able to provide it. And so last flu season, every year in the fall, I think we're used to having a flu season. We're usually busier than normal. All immunization providers are. We're working to get everybody vaccinated for influenza prior to the new year. But last year was a different year. We had our usual annual flu vaccination that we were working on. But at the same time, COVID vaccine was being commercialized, meaning it was moving from being supplied by the federal government to being a mixture of purchased privately and then insurance billed. And then also we were implementing COVID vaccine in the Vaccines for Children program. At the same time, awardees were implementing the COVID vaccine bridge access program, which provided COVID vaccine to uninsured adults last year. And then programs were able to provide an offset to providers who gave that vaccine to uninsured adults. And then we had RSV products finally available, which is wonderful. We finally had a way to prevent RSV. We had 2 vaccines available for adults 60 and older through shared clinical decision-making. We also had a vaccine available for pregnant women, which protected the infant during the highest risk months of life. And then we had Nursivimab, the monoclonal antibody product that was available for young infants and children. And so all of this was happening around the same time last fall. So some of the challenges, especially that we had with Nursivimab, the monoclonal antibody product, we found out pretty late in the fall, or later than would have been ideal, that the product was going to be added to the VFC program. Now, that's a wonderful thing that it was added to the VFC program because it allowed children eligible for VFC to have access to Nursivimab. But it did come with some challenges, including the VFC program has fairly low enrollment of birthing hospitals in the program. About 10% of birthing hospitals in the United States are enrolled in VFC. And so a lot of the birthing hospitals did not have access this last season to VFC Nursivimab. We weren't able to communicate with providers about whether or not it would be available in the VFC program and what they needed to expect. And then some providers, due to the cost of Nursivimab, did not necessarily want to stock Nursivimab on the private side. And a lot of them want to give to both VFC and privately insured children, and so they don't want to have an inequity there. We are all aware of the supply challenges there were last year with Nursivimab. There wasn't a sufficient supply, and that kind of led to unequal distribution. So oftentimes providers would have enough VFC, but not enough for insured children. And they like to treat those children in the same way. And so they struggled with decisions about who they were able to give Nursivimab to. And then it was also different across jurisdictions. There were also challenges implementing Nursivimab in the IAS and electronic medical records. It is a monoclonal antibody, not a vaccine. And so it's just treated a little differently with the codes. A lot of times newborns in birthing hospitals don't yet have a name established. And so the electronic medical record will send baby girl A or baby boy B to the IAS and not necessarily the actual name of the child. For the older children who are recommended to have Nursivimab, they need 2 doses of the 100 milligram dosage. And a lot of IAS will see that as a duplicate and want to delete one of those doses, but really both doses should be recorded. And so IAS had to come up with some creative ways to get around that. And then just overall making sure the codes were in our system so we were able to accept Nursivimab doses in our IAS. And then insurance coverage. After ACIP recommends a vaccine, they have a year to start covering that vaccine. And so Nursivimab, the recommendation came pretty late last fall. And so not all insurance companies were yet covering Nursivimab. And then at the birthing hospital, Nursivimab's included in the bundled payment that they receive from insurance. And so that was a barrier for a lot of hospitals to buy a product that's rather more expensive in comparison to other immunizations, and then have it covered in the bundle and maybe not all of their costs being covered. And then, of course, just ensuring that all insurers and Medicaid were starting to cover the product. For older adults and the RSV vaccine, there were additional challenges. One is just collecting data. Adult participation in the IAS is not as great as it is for children, especially with long-term care facilities. A lot of long-term care facilities don't necessarily report to the IAS. Also making sure that there was access to the product. A lot of this was given in the pharmacy and not necessarily at provider offices. And so if you went to your medical provider, you maybe didn't have access to the RSV product and would be referred to a pharmacy. And then just making sure with all the products that were out there, keeping providers up to date and the public on which products they were and not to give incorrect dosages. For older adults, many of them don't understand the severity of RSV. And so it really was about educating people 60 and older what their risk was about RSV, as there's a lack of awareness of RSV severity in the older population. So according to CDC's respiratory dashboard, these were the rates for this past respiratory season for immunizations. You can see uptake varied by immunization type. We did pretty good with flu for older adults, but definitely room for improvement in the RSV and COVID area. But not too bad for it being the first year that an RSV product was available for that population. And then just overall for children, flu vaccination rates have been declining in the US, so there's definitely room for improvement there. But for the first year for Nursivimab to be available and for there to be kind of a shortage of the product, over 40% is pretty good rate for that product. And so there was pretty good acceptance amongst parents for that. And then also estimating the maternal with that at 17.8%. If you combine those two, that's pretty good protection of infants for the first year for products to be available. And so looking towards this fall, we're already preparing for the respiratory season. There are increased efforts to enroll birthing facilities in the Vaccines for Children program. AIM partnered with the American Hospital Association to develop a fact sheet, which birthing institutions and awardees can use to kind of show how easy it is to be a VFC provider, that it's not that much of a hurdle, and what's required of birthing hospitals to be a VFC provider, and just overall working with other providers to make sure we have adequate access to VFC and Nursivimab across the state. In North Dakota, we developed a tip sheet for providers. We even had this last year so that they would be ready to offer Nursivimab, and it included information from setting it up in their electronic medical record to having adequate storage and handling and how to supply it and screen for it. We've really been working with birthing hospitals so that they understand the requirements for being a VFC provider and administering Nursivimab this coming fall. We're lucky in North Dakota that most of our birthing hospitals are already enrolled in the VFC program. That's fairly unique in the United States, but other awardees have a significant lift enrolling hospitals in the VFC program. We're looking forward to having reminder recall functionality established in our IAS so that we're able to send reminders to children who would be eligible to receive Nursivimab this fall. We're planning for potential allocations of supply, which mean then we have to allocate it out to our VFC providers to make sure it's equitably distributed across our state. And then we're working towards having a dashboard for the respiratory season. So we've had separate dashboards for COVID, flu, and RSV. And so we're looking to have those combined and have one dashboard that lets the public and providers know how we're doing with respiratory illnesses and immunization. AIM did survey its members on a recent call in how they're preparing to educate the public or having a communication campaign for the fall on immunizations. And the majority of AIM members are going to be promoting it based on a respiratory season and not doing individual communications for each separate disease. But there still were a fair number of AIM members that weren't yet sure about how they were going to communicate about the respiratory season. And I think this last slide just shows some examples of what some of the awardees have put together to promote respiratory immunizations. Idaho did "'Tis the Sneezin'," which I think is pretty cute. But there's many more examples out there of great work that AIM members are doing. So thank you for your time this afternoon.
Thank you, Molly. I am going to present this from one of my other hats. I'm presenting this in my role as medical director for the National Foundation for Infectious Diseases. So for those of y'all who may not be familiar, NFID is a nonprofit organization dedicated to educating and engaging the public, communities, and healthcare professionals about the prevention and treatment of infectious diseases across the lifespan. And we've been doing this as an organization for over 50 years. Each year, NFID has conducted a nationally representative survey to help better understand consumer knowledge, attitudes, and practices toward influenza, pneumococcal disease, and as we've added COVID-19 and RSV the last couple of years, those have also been added. And these are some of the data that come from our website showing some of these responses. Since 2019, NFID surveys have consistently found that 60% or more of U.S. adults agree that flu vaccination is the best way to help prevent influenza-related hospitalizations and death. Yet, each year, 40% or more of U.S. adults say they either don't plan to get an annual flu vaccine or are unsure whether they're going to do so. Of concern, 20% or more of those who are at higher risk for flu-related complications don't plan to get vaccinated. In the surveys, higher risk is defined as adults aged 65 and older, and those who have chronic health conditions, including heart, lung, kidney disease, and diabetes. And the proportion of those who don't plan to be vaccinated was a bit higher in 2023 than the prior 4 years. There are also consistent themes on the reasons people give for not getting vaccinated. Although concerns about vaccine side effects, efficacy, and false beliefs about the vaccine causing disease were similar for both flu and COVID-19, there were some distinctions between the responses, including underestimating the potential severity of flu and mistrust of COVID-19 vaccines. This is a reminder of the importance of clear, targeted, disease-specific communication that starts with asking questions to better understand your audience regarding their motivations and their concerns. Survey findings reinforce the importance of raising awareness and addressing misconceptions and the need for healthcare professionals to provide strong vaccine recommendations to their patients. Overall, survey findings underscore the need to build trust and dispel myths about vaccines by informing the public that even in cases where vaccination doesn't prevent infection completely, it does reduce the severity and the duration of illness and can help prevent serious complications, including hospitalization and death. NFID offers a number of tools and resources to help healthcare professionals and public health champions to address vaccine hesitancy and build vaccine confidence. Links to our webinars, videos, graphics, and more can be found on the NFID website that you see referenced on the slide. And now I want to turn briefly to what we saw during the 23-24 season with some data from CDC on vaccination, first for influenza and then for COVID-19 and RSV. Regarding influenza, the three key take-home messages from my review of the data are, number one, there's wide variability in uptake of flu vaccine across the U.S. geographically, as well as by urban and rural residents, by income, by race, and by ethnicity. And this slide emphasizes the geographic disparities. Vaccination rates increased throughout the influenza season, yet despite the efforts of many, roughly 25 to 30% of the population who reported they definitely will not receive the vaccine, an additional 10 to 15% who are unsure really didn't change throughout the season. And our vaccination rates across different segments of the population were not much different this past year than the previous years. Did increase through the season, despite an initial slower uptake than we'd seen in the previous 2 to 3 years. COVID-19 vaccination is a similar story, but with much lower overall vaccination rates. Variable uptake by different states, by rural, suburban, and urban areas, by income, race, and ethnicity. We still have a very long way to go to convince the U.S. population of the critical importance of COVID-19 vaccination to reduce the risk for severe disease and related complications. I can't count the number of times I still continue to hear, well, there's no point doing COVID vaccine. It doesn't prevent you getting illness, but it gets you out of the hospital. It reduces your risk of dying from the disease. We need to continue to reemphasize that message. Finally, for RSV, this slide shows the wide disparity in racial and ethnic uptake of RSV vaccine in this first season for adults 65 and older. This is part of the population for which the benefit will be greatest and coverage should be less of a challenge. Again, we have a long way to go to reach our goals. So, we have survey data and know how we've done in vaccinating adults during this previous season, where do we go from here? I want to spend a couple of moments discussing how we need to continue to work together to optimize the 3 C's of vaccine hesitancy: confidence, complacency, and convenience. Based on the NFID surveys and numerous other resources, we know that healthcare professional recommendations are key to vaccine uptake for most adults. To get that strong healthcare provider recommendation, our healthcare professionals need to be confident in the value and importance of vaccination. And unfortunately, there's data suggesting a slip in healthcare provider confidence during the COVID-19 pandemic. We need to use the trust that we've earned, recognize the challenge, and systematically address healthcare provider concerns by explaining changes and recommendations, providing current and regularly updated resources to help restore that healthcare provider confidence so that we can then provide confident recommendations to our patients. Our healthcare providers need tools and resources they can use in their day-to-day contact with patients to improve utilization of individuals and communities, which will be reflected in increased vaccination and protection of our communities. We have an opportunity to address public confidence by improving vaccine literacy. Simple, science-based information could be available as memes and graphics, educational modules, and even curricula focused on organisms, diseases, and vaccines using relatable examples. In the longer term, incorporating vaccine value education in middle schools in their curricula, if not even earlier, will improve the likelihood for long-term confidence in this individual's opinion. We need to be active on social media. We need to provide positive messages about vaccine benefits and value. The data on refuting anti-science and anti-vaccine messages is unfortunately much more mixed. And we need to recognize the impact of the pandemic on mental health and anxiety levels. Our one-on-one conversations need to take this into account, and messaging needs to address vaccine safety and disease risk. And finally, we have to recognize that mandates can have both positive and negative impacts. While important for protection of those who can't be vaccinated and preventing outbreaks, they can be perceived as intrusive and can increase vaccine resistance even more in our polarized political climate. Complacency is always going to be a challenge. Providing information about disease and risk without being perceived as fear-mongering can be a delicate balance. And while outbreaks are far from desirable, their occurrence may help activate those who are hesitant to move beyond complacency. Supportive conversations in clinical settings, as well as building collaboration in communities to help support a culture of immunization, can also help minimize some of this complacency. Convenience, as they say about politics, is an issue where the source and the solutions are all local. Patients need easy access to appropriately reimbursed vaccines in offices, in pharmacies, in public health clinics, in community health centers, and others. As Mitch has said for many years, it's an immunization community. Convenient access, along with minimizing the direct and indirect costs of vaccination to our patients, is critical. There's data to support co-administration as a strategy to improve vaccine uptake. And robust immunization registries can help ensure that we get the right vaccines to the right individuals at the right time to improve the health of our communities. The goal is simple: no vaccine, no missed location, no missed opportunity. NFID will take every opportunity throughout the respiratory season to help increase awareness and build confidence and motivate people to take action. We held an adult vaccine roundtable earlier this spring and plan to have a high-level report available by the June ACIP meeting. And the full report will be available later this summer. And I would appreciate all of you spending a few minutes when it's out. We'll again conduct a national survey this summer and collaborate with CDC and others in the annual news conference in September. Multiple ongoing strategies, as you see reflected in this slide, will help keep the momentum going throughout the season, including leveraging national health observances. I want to thank you for your time and attention, and I'll be happy to answer questions following our panel presentation. And our final presenter in the panel is Dr. Brendan Jackson. Dr. Jackson, I see you on the slide. Your slides are up, and I see your face.
Great, thanks so much, and really appreciate the opportunity to be here with you. These were fantastic talks, and I think they intersect well with the things that I'm going to cover here. The next slide, please. So at CDC, we're very committed to focusing on preparing for this fall and winter season and addressing many of the issues that you brought up today. I know everybody knows this, but I feel like it's worth driving home that there's some simple math behind what's going on behind these respiratory seasons these days, and that is 2 + 1 = 3, right? Before the pandemic, we had 2 viruses that were particularly bad that we were dealing with, causing the most hospitalizations. And now we have COVID on top of that. And has been pointed out, we're no longer in the emergency status for COVID, but it's here and it's causing a problem and it's making the average season that much worse. So next slide, please. This is, I think, a helpful thing from our last year's respiratory season outlook. We'll be doing a new one in the next couple of months. And you can see on the left there, that gray bar represents peak hospitalizations from flu and RSV combined in a pretty bad flu season. And you can see in the middle, sort of the Omicron wave and the first year of the quote unquote triple-demic as flu and RSV came back. And then the orange was modeling for this past season where we might be. And what I think is important to note here is that even a moderate season of any of these things is worse now than a severe season in the past. And if you make it severe, it's that much worse. And we actually ended up at the higher level of this. So on the next slide, please, you can see that in the black line here, this is hospitalizations over time, and the dark line is this past season. The dotted line is the year before. That black line is combined all three, very similar levels to this year versus the year before. Fortunately, I think we saw less healthcare overwhelm, but I think probably as health systems rebounded a bit more from the pandemic, but things still got very tight. That's a lot of people getting very sick, and unfortunately, a lot of people dying as well. The flu season and RSV season looked very similar to the year before, just kind of shifted forward by about a month, more typical timing. COVID was down, thankfully, year over year. We don't know that that will hold again, but hopefully we'll continue to see that decline. But I think it's important to note that COVID still was causing more hospitalizations than either of the other diseases at almost any point here. And of course, we may be heading towards a summer wave for COVID, at least on a slight uptick here, and we shall see. That's pretty typical from what we've seen for these past few years. Next slide, please. So as you all well know, there's vaccines now to prevent all of this. And we've got an infographic summarizing that. We're working on simpler ways of conveying this all as we go into this fall and winter. But as has been said, uptake is lower than we would like. So on the next slide, will look very familiar. I just want to underscore on that far right there, the immunization rates that are particularly suboptimal for older adults. You see 41% of older adults got the COVID vaccine. That's 73% for flu. That's not because COVID is less severe than flu. People have just discussed the reasons why that uptake is low, and it's part of our collective job here to help get more people protected. Next slide, please. I want to emphasize we have a number of places where people can see these data very simply and easily. So we have this respiratory virus data channel, and it's got a weekly snapshot, what's going on with the overall virus. It tells you what's going on with activity levels, illness severity, but also vaccination trends. And that's sort of a one-stop shop people can just go to and get a weekly look at where things are headed. We'll be updating this again once the new vaccines roll out in August to September. And then on the next slide, you can see, it's already been referenced, we have this RESP-VaxView page, which has COVID, flu, and RSV, very detailed vaccine information all available. Shannon Stokely, I know, is talking at this meeting as well, in more depth about vaccine coverage data. Next slide, please. So a little bit of learning from last season. Ms. Howell already covered a lot about some of the nirsevimab issues, and we're really looking to see what we can do to mitigate those, continue to mitigate those as much as possible. I think some of that was related to it being a new immunization. It's the first time we've sort of had a monoclonal, long-acting monoclonal like this in that space. And there was also the supply limitations that were going on at the time. So we think that those have been resolved. There's still some leftover supply from this year, more coming in for next season. So knock on wood, things should be good in terms of that. She also mentioned the fact that this was the first year that COVID vaccine was available on the commercial market instead of provided by the federal government. And we all saw the challenge when people got in the habit of, once FDA made their decision and FDA and CDC made their recommendation, people went out to the pharmacies and to their healthcare providers to get those vaccines, and they weren't always available because this was more on a flu vaccine distribution timeline, sort of a non-emergency timeline. And we're going to be working to message that about when vaccines are available and when they're going to start percolating their way through the system to become available. It's not one of those things where people necessarily need to rush out right away, but they absolutely need to get them. Next slide, please. Well, talks about how the 7 different areas, calling them work streams across CDC, that we're looking to really coordinate and make this as effective as possible from at least our side here, working with federal government partners and partners across a wide range of groups. Talked a lot about vaccine planning and operations already, so a lot of discussions with manufacturers, with AIM, with many of the immunizers and that type of thing, to make sure that that is as seamless as possible. Understanding Murphy's Law always applies. Talk about data. I'm going to talk a bit more about communications, community and partner engagement, and provider engagement, since that's so critical based on what has been already talked about today. Long-term care, I'm not going to talk about further, but want to emphasize this is a critical group. We know that vaccination rates there, especially for COVID, are decidedly suboptimal. This is essentially one of the highest risk groups, and looking for ways that we can help be part of the solution to increase vaccine coverage there. And then, of course, testing and treatment is something we're focusing on, not directly relevant to this meeting, but an important layer of protection. Next slide, please. So just as a reminder, in terms of where we are now, quick status check on the vaccines. People are aware of the FDA Advisory Committee meeting last week, where they selected the monovalent JN1 target for the COVID vaccines. That's despite the fact that there are offspring of JN1 in this variant soup that's out there right now, and saying, well, why aren't you targeting one of those new ones? I think they have made a good rationale for why, that it doesn't make sense to target every little one. This one's going to cover that wide range of them. It's also going to be less likely to lead to any delays in manufacturing, make the vaccines available as soon as possible. Next slide, please. And then flu vaccines, the main change here is that we're moving from quadrivalent to trivalent flu vaccines. That's just removing the influenza B Yamagata subtype, which has not been seen around the world since 2020. So good reason to switch to 3 targets instead of 4. So that'll be 2 flu A and 1 flu B targets for this year's vaccines. And the next slide, just a reminder that the Advisory Committee for Immunization Practices is coming up in just a couple weeks here at CDC. They're going to provide talking about a whole bunch of data related to COVID, flu, and RSV. I want to remind folks, as opposed to in the past where there was sort of like for COVID vaccines, there was an FDA meeting and then a sort of an emergency ACIP meeting. The intent is to address this fall's COVID vaccines at this meeting, so there's no need for any further approvals or recommendations by CDC after that point. At that meeting, there's going to be a particular focus on the adult RSV vaccines, some data on safety, efficacy, effectiveness, economic analysis, really talking about those benefits and risks, which is important given that there's now a shared clinical decision-making model, which some say are maybe limiting uptake in certain populations and also raises sometimes equity challenges. So a lot of discussion is going to be happening around sort of recommendations for especially around older adults there. Also some data on revaccination at a 24-month interval, and then co-administration data, which Dr. Hopkins already mentioned. Co-administration is such an important practice, and I think the more data we have on that, the better. Next slide, please. In terms of communications, last year, we were in a challenging situation overall where basically the remaining COVID funding was largely rescinded as part of a larger congressional budget deal. And so there was a larger campaign that was pulled back and never released. So CDC pulled together what funding that we could, put together a small campaign that was called the Everything Campaign. Many people probably didn't see it because there was not a large budget behind us. We are excited this year that HHS has more funding and is planning a campaign right now, and we're doing what we can to support that, especially as they are targeting or trying to really drive up coverage in groups at higher risk, like older adults. And including by working with healthcare providers as a core strategy there. Next slide, please. The wild to mild flu campaign will also still be continuing. I think this is a really helpful thing. As people mentioned, the flu vaccine does not necessarily keep you from getting flu, but what it does is it can take it from a potentially wild and potentially dangerous disease to something that is generally much more manageable. And I think this is really a similar story for COVID and RSV to a great extent as well. Next slide, please. Reminder that vaccines.gov is still out there. We are re-upping it coming this August, essentially. And so as the new vaccines become available, we're going to be providing easy linkage for people to find out where they can get those vaccines through this, understanding this is not the only place that people are going to be able to find where they can get vaccines. Next slide, please. And just to drill down for a second on healthcare providers. We are 100% agreement that healthcare providers are absolutely critical as a trusted and welcome messenger for getting increasing vaccine uptake. We had this toolkit from last season that tried to lay out what was healthcare providers needed to know and how to talk with their patients. On the next slide, you can see that we're really trying to revamp things even further. Understanding, we're hearing clinicians saying shorter is better, right? So looking to streamline information as much as possible, given what they need to know, when they need to know it. And again, what I need, when I need it, really focusing on strategic outreach. We're doing a lot of engagement with clinical partners. I think 100 events by September is our plan, but much more than that as the season progresses. And then finally, put the information in the tools that I'm already using, just make it part of the workflow. So integrating public health practice into healthcare, whether it's part of the electronic health record or in certain online web resources that they use very frequently, working with those types of groups. Next slide, please. I do want to mention access, as Dr. Brunson mentioned up front, is critical for vaccines. And it's unfortunate to say that Bridge Access Program, Ms. Howell already mentioned, is going to be ending in August. That's because of the budget is no longer there. And that means we're going to be, what this has done already, that's 1.5 million plus people vaccinated for COVID vaccines, unvaccinated or uninsured adults that would not have been probably vaccinated otherwise, got it through this program. We're going to be going into this next season without that. I think this underscores the importance of the idea of a vaccine for adults program to complement a vaccines for children's program that's already been put in the president's budget. Whether that will become a reality, I don't know. But we definitely face a season where there's a lot of uninsured adults that may have trouble reaching vaccination. So that's going to be a clear partnership gap and need that we're going to have to work together on. Next slide, please. And finally, I just want to mention very briefly something that we're all watching very carefully, working on carefully here at CDC, and has been in the news, the influenza H5N1, the bird flu issue that's primarily right now an animal issue, spreading in dairy cattle especially, but as well as a number of other animals out there. It's a potential risk to workers. So far, fortunately, all the illnesses that we know about so far have been mild, and the overall risk to the public at this point still does seem to be low. But we know from COVID and many other situations in public health that things can change quickly. And we know that hope is not a strategy. And so doing as much preparation just in case. As part of that, I know Asper has worked with vaccine manufacturer to help make up to 5 million vaccines available, potentially if needed in the next couple of months. In the case that is needed, it's most likely that it will not be, but just in case. And then no specific decision on when and who and where those vaccines would go for. And it's really going to depend on what happens as the situation evolves, and certainly trying to make sure that we're in a position to scale up even further in vaccines in the unlikely event that is needed. So I will wrap up there and say thank you on this next slide. Thank you again for all the partnerships here. Really want to stay closely connected with you, provide whatever support you need. Do not hesitate to reach out if you have thoughts and needs as we go forward. Thanks.
I want to thank the members of this panel. Are there any quick questions or comments from members of the committee, either here in the room or online? Mitch?
Yes, thank you for the presentations. It may sound like a broken record here, but it's important in this particular area. As we're coming into the respiratory season and we've got the movement from the free vaccines to now the commercial market, one of the barriers that providers across the spectrum are facing is the constriction in resources within the healthcare system. And that now that they're going to have to lay money out of their own pockets to pay and purchase those vaccines and then wait for reimbursements, is going to become a barrier for providers stocking vaccines or sending them to other providers who may or may not be able to provide it. And so I think it's important from a government perspective that we really take a look at what are the policies that we're advocating to payers in terms of prompt payment, adequate payment for providers. We've got no copay under the IRA, but what was never addressed is how are providers going to be able to purchase and maintain that supply and not go out of business. So as any discussion been talked about at CDC and in HHS and other agencies about how we're going to approach that so that we don't lose providers when it's so important for an access point.
It's a really important point. And there's been a lot of discussion about cost barriers and access barriers, and making sure that clinicians are fully supported. As you know, the payer issues are largely out of CDC's control, but definitely in close communications with CMS and other groups in those areas. There may be to some extent a larger, more legislative solution needed for that, but definitely we'll take that back as well. Thank you.
Great. Well, I want to thank all the members of this panel. I'm going to take Dr. Brunson's equation she gave us earlier and frame it slightly differently. Choice plus access equals uptake. I think that's one we need to keep in all of our minds. Thank you all. Our next panel is Outbreak Update, Measles Cases in Chicago and Cook County. In March of this year, the Chicago County Health Department confirmed the first case of measles in Chicago in 5 years. On May 30th of this year, the office declared the outbreak over, with 2 full incubation periods for measles having passed without new cases. During the time, over 30,000 vaccinations were administered and 67 cases were reported. The Chicago Department of Public Health, the medical community, parents, and others also responded with proactive approaches to help prevent further spread of measles in the area. So to help frame this for us a bit, we have 2 presenters. We're going to have Commissioner Olusubo Ige from the Chicago Department of Public Health, and please pardon me if I mispronounced, and Dr. Frank Belamonte from Advocate Children's Hospital. Dr. Ige, I see your slide on the floor and see your face. You have the floor.
Thank you so much, and thank you for this opportunity. I am Simba Ige, and the Commissioner for the Chicago Department of Public Health. We have good news. We have a success story in public health. That's not always our situation, so we're very excited to share this good news that we were able to control an outbreak of the magnitude that we did within the time that we did. Next slide, please. And the reason we're sharing this story is there are some new migratory patterns that is impacting our work in public health that is important for us to continue to plan for. All over the world, we're seeing changing in migratory patterns, and I think that in public health, we have to be prepared. This is our scenario in Chicago. An increased pool of unvaccinated people who were in close quarters. This is not the typical context of what we see in public health. In Chicago, we have had over, as at today, 43,000 new arrivals since August 2022. As at the time of this outbreak, we were operating 27 shelters, and there were over 14,900 residents in the shelters. So we had, in very close quarters in shelter congregate setting context, a large number of people who were unvaccinated. Next slide, please. So another piece of information that I think is relevant is, on the one hand, we had this large number of unvaccinated people in close quarters, and then in the larger community, lower MMR coverage than we had historically. So we had very high coverage in Chicago, one of the highest in the country, very proudly. But over time, especially from just before the pandemic and since the pandemic, we have seen a continuous downward trend in the MMR coverage. So these 2 pieces of information is very important because it informed the actions that we took in responding to this outbreak. Next slide, please. So we had our first case of measles on May 7th of 2024. That's when we received that notification. By the time this outbreak was over, we had recorded 64 cases. And the demographics here is very important. Most of the cases we saw were within the ages of 0 to 4. That made up more than half of the cases. And then the other, large demographic group that was impacted was those 18 to 49. And again, this is very typical because we were talking about young families in family shelters within the city of Chicago. So we saw that bipolarity, the parents and then the children. We didn't see as many within children of school-bearing age, and then those who were over 50. Next slide, please. Now, this outbreak gave us a lot of concern for many reasons. First, it was the first outbreak we've had in 5 years. but it very quickly became the largest outbreak in Illinois since 1980. Again, for these two contextual issues that I started with, the large pool of unvaccinated people who were coming into the city in close quarters, and then the decrease in MMR vaccination coverage. And you will see here, like the last time we had an outbreak that was even close to 64 in number was after 1980, since the Illinois law for strengthening school vaccination was enacted, we haven't had an outbreak of this size. So this is significant because now this new context, these new migratory patterns is opening the door or starting new trends in outbreaks that are significant for us to be prepared for and have the public health infrastructure to respond to. Next slide. So not just that this is the largest that we've seen in a long time, and it also became the largest measles outbreak in the country. So 64 is not a typical number that we see in the United States for measles. I mean, folks were asking, like, you have this kind of outbreak in the United States? Again, this is an evidence of global trends, trends across the United States, but it is significant that we are increasingly prepared for this kinds of scenario. It might be measles now, but there's no telling what it could be, what other virus or bacteria could also emerge in populations, and because of the changes we're seeing in big cities. Next slide. So this is the context in which we're operating, and I wanted to lay that foundation so that you will understand our response. But there were other nuances that also make this a very, very politically charged climate. The whole conversation around new migrants and new arrivals and being a welcoming city was a very particular political context within Chicago that is important to note. We had, like other speakers today have discussed, very limited resources. There was no declaration of an emergency. There was no federal funding available. There was no additional state funding available. So we were working within very, very constrained context. Funding, staffing, vaccine supply, all of that was very limited. We also, even though the possibility of a vaccine policy was possible at that time, at the time of this outbreak, there was no vaccination policy. Again, making vaccination required. Refugee health and protocols at the borders before now was such that people were getting vaccinated who are refugees coming into the United States. But this was not the case here, where we were seeing people coming in from the borders, landing in Chicago with no previous vaccination, no vaccination policy to prepare us for this kind of outbreak. And we also wanted to be diligent. When I got this notice, March 7, 2024, at 9 p.m., when we got this notice that we have a measles case within a new arrival shelter. This was a shelter with 2,500 residents, and it was open congregate settings. So my first thought was that, oh my word, we have 2,500 people exposed to measles. And knowing measles and how contagious this is, 9 out of 10 people who are exposed will contract measles. So we had to spring into action immediately, but it's one thing to understand what needs to be done and the resources that we need to do it, and the very charged political context in which this was operating, because we didn't have the luxury of, like, we're going to wait this out. If this get into the larger community, it will just, again, ignites the fire and the negative sentiment around migrants coming into the city. But we wanted to also understand from the perspective of the residents. We couldn't just show up there and say, oh, we're here ready to vaccinate. The first 3 hours, people were not having it. People didn't want to be vaccinated. We were going from bed to bed, saying we're here to get vaccinated. We had a measles case, and everyone here is at risk. We want to vaccinate you. And people were not having it. So we had to spend a lot of time trying to understand what the concerns were. We've had other outbreaks of contagious diseases in the shelters. We want to take this seriously. We don't want this to spread, and we have vaccines. But what we discovered that I think it's interesting to share is that people were concerned about their ability to work. If I get these vaccines, you're saying that even if I get these vaccines, I still need to stay in quarantine for 21 days. I want to be able to go out and work. I want to be able to get out of this shelter and make a living for my family. That was a primary concern, especially for the adult males, which was very, very difficult to get them to a yes. Access to schooling. Parents were worried about their children. Will my children be able to go to school? What will I do with them if they're not able to go to school? If they're not able to go to school, then I can't work and I can't look for jobs, etc. And they were also worried because in the shelter, what they had to eat is what was offered. And not being able to leave and staying and getting vaccinated, etc., meant that they will not be able to explore other culturally appropriate meals for themselves and their children. So these were not the typical things that we were expecting to hear about vaccines, or like, oh, we don't trust the vaccines, or we don't want them. These were the issues that we found to be dominant in the minds of people. And these were the things that we had to resolve. So bringing in food from the public school menu as additional options, making sure that we could make arrangements for books and mobile computers for the children who were missing school so they could stay connected, and then writing letters to employers from the public health department saying there has been an outbreak and therefore this person cannot come to work, were some of the other interventions that we had to provide to get people to a yes. Next slide, please. So this is sort of a summary of our response, the outbreak, the timelines. This first case of measles in the new arrivals shelter was on February 26th. We were notified March 4th that there was a potential case, and we got the PCR confirmation on March 7th. And on March 8th, we rolled into action within 24 hours, started the movement restriction, public school exclusion, and we started the vaccination campaign at the shelter. And over the next couple of weeks, over the next 3 days, we vaccinated 99% of everyone who did not have record of vaccination in our immunization registry. And by the 12th of March, we started to move our vaccination efforts to other migrant shelters. I said, before we had 27 shelters at that moment. So moving vaccination operations to other shelters became the phase 2 of the work. And then phase 3, we started to see breakthrough cases pop up after the initial vaccination effort. So the shelter worker case, a shelter link community case, and then we started to see cases pop up outside of Chicago and outside of the shelter. And we launched a second dose vaccination campaign at the shelter from April onwards. And then we were able to declare this the outbreak over by the 1st of June. Next slide, please. Now, the other thing that we wanted to highlight is that the first round of vaccination campaign was very important, the 1 dose. And we were working with a scenario of, 93% vaccine effectiveness should get us to a good state. What is different here is the congregate setting. We did not have resources to quarantine hundreds of people. There was no way to demarcate or put separation within the family. So again, big warehouse context. So the breakthrough cases we saw here were significant. And then it became the second wave of the cases that we saw. If you refer back to the initial slide, you will see the initial peak and then a smaller peak after the first round of vaccination. So this was our estimation at the beginning that, if we account for 7% vaccine failure, there will be about 4% of the population that will develop measles and will potentially be as sick as if they had no vaccine dose at all. And then there will be a 3% secondary vaccination failure, where we'll probably see attenuated cases with some level of protection. So we anticipated of the 430 people that we knew had no historical first dose before the outbreak, we will estimate that about 30 cases will emerge of vaccination failure or breakthrough cases. What we saw in actual numbers was about 17 cases total, 13 cases after dose 1 and 4 cases after 2 doses, including some of the shelter workers who developed measles even after 2 doses. and they had no immunological failure or HIV or any other immunocompromising conditions. So congregate settings, the pressure of the exposure led to a higher rate of vaccine failure than we anticipated. Next slide. So that led to another layer of response. In addition to a vaccination effort, it became necessary to exclude particularly younger children less than the age of 4, where we were seeing most of the breakthrough cases emerge. It was not sufficient for them to have the 1 dose and wait 21 days. We then started any child who's older than 12 months who had a first dose on the 8th of March to the 11th of March. During that first vaccination, mass vaccination campaign, making sure we were able to get them their second doses as quickly as possible. That's 28 days later, wait 21 days before returning to school. Again, in this context, we had no quarantine facilities. So giving second dose, expedited second dose was another layer of action that we took to sort of keep this in check. Next slide. So this required, again, a lot of engagement and socialization with our partners, the Chicago Public School, and just reinforcing, again, parents wanted their children to go to school. There was a lot of anxiety around other public school students. 2 doses of vaccines within the 28-day period, people wondering if it was safe, can you vaccinate this quickly? So there was another round of education that was necessary, and us repeatedly pointing to this is a policy, this is an approved practice, and we're not just changing the practices for this population. So highlighting that 2 doses of measles vaccine, the first dose must have been received on or before the first birthday, and the second dose no less than 4 weeks is standard practice, and it was not a change or will be lead to a higher risk of side effects for the population. So this required a lot of engagement with policymakers, our public school partners, and parents to help them feel comfortable with the second dose. But we did still have a lower uptake for the second dose than we did for the first dose. Next slide. So these are some of the solutions that we had to deploy based on the context, based on the politics of what we were dealing with. We had to leverage partnership in a way that was unprecedented. IDPH, our state Department of Health, had to deploy staff and support for us. We had to pull out a call for mutual aid across all the different counties in Chicago to support this response. Cook County Health had to take on symptom monitoring and deploy some of their nurses to help us at the landing zone as new arrivals were coming in. We had to engage the elders, these are the leaders of the wards, in messaging and education and going from bed to bed and convincing people that vaccination was necessary, and then quarantining or staying in place for 21 days after the vaccination was necessary. The healthcare system partners were vital. We had to engage 16 volunteer healthcare provider systems to support us in this effort. The Mayor's Office of Immigrant, Migrant, and Refugee Health with our community engagement and messaging to the immigrant community, folks who were very worried about our response to this measles outbreak, community-based organizations, faith-based organizations, faith leaders. We had to bring in all trusted community voices to help reinforce the messaging over and over again to get people to say yes. One of the key messages we want, or key learnings that we wanted to share, is that addressing social determinants of health is necessary. When people are concerned about other issues, just telling them about the benefits of the vaccines is not sufficient. And making sure these resources are available to increase trust and comfort with the vaccination campaign was one of the key learnings here. Next slide, please. So at the end of all of this, we are very proud to say we were able to administer over 31,000 doses of the vaccines. We put in this chart just for you to have a visual of what vaccination was before March 2024, and how our operation just led to a doubling of the number of doses that will be typically administered within this time frame. What is important here is that we did not only succeed in getting the new arrivals vaccinated at almost a 90%, 99% coverage level, is that many of these doses were also administered at the community level. We were very careful about our messaging to ensure that people knew that the best way to protect yourself from measles is to get vaccinated, is not to lock up the new arrivals or to throw them out of their shelters, but for you to be vaccinated. If you're vaccinated against measles, you are safe, was our messaging. And if you are not, please get vaccinated. And that led to a double win, getting our new arrivals vaccinated and getting more children of school age vaccinated who were previously not. So this took a massive effort, 226 vaccination clinics, 31 shelters, landing zone. We were able to implement a new vaccination requirement for those who were coming into our shelters, over 20,000 vaccinations outside of shelters. This was school age folks mostly who caught up with their vaccination as a result of this outbreak. And we're very proud to say that there were no fatalities from this outbreak. Next slide. So messaging context. There's been a lot of conversation today already around how do we message in public health. I think understanding our context is very important so that we can tailor our messaging appropriately. I started by saying we had over 43,000 new arrivals in Chicago. It was a politically charged environment. And this is a sentiment analysis that we did as part of our response in partnership with a social media company. And what we found that the prevalent theme in the narrative or in media interaction was around the anti-migrant commentary. People really were concerned about removing the migrants from the city. That was what was prevalent in the city, and it was 22% of all online interaction. People using terms like illegals, and these are asylum seekers. They are here legally, they have the papers. News of possible exposures in public spaces also became a theme, and people were worried, oh, we have been exposed. So we had to, on our measles dashboard, start to detail where there had been public exposure. So people could know if you were on train XYZ on such a date, you could have been exposed. Please reach out to us to sort of address that concern about public exposures to measles. So detailing and presenting every day where there had been public exposure and doing contact tracing. There was also a lot of concern around shelter evictions and measles getting spread into the larger community. Even though our index case of measles did not start in the shelter, it was a community member. There was a pervasive concern around shelter evictions and us quarantining and locking down and making sure nobody was getting out of the shelters because of the concern. So giving people cards to say they had received their 2 doses, they are immune, they are allowed to go out, also became part of our response. And then what became a concern to us that in spite of our best efforts, we had podcasts, we had Facebook Live, we had public press conferences around the work that we're doing, the vaccination messaging and the vaccination policy did not garner the same kind of media attention as all of the other things did. So we continue to have a need in public health to how do we engage our communities and our audiences around vaccination as the tool, as the way to be protected against infectious diseases. There are other tools that are helpful, but primarily we want you to be vaccinated. If your children are vaccinated, they are protected from this disease rather than the prevalent theme around other measures, removing people. So careful messaging, even when we're talking about the source of an infection or the index case, there is a potential for this to be hijacked and fuel anti-migrant commentary. We learned that from COVID. So we were very intentional about saying that measles is a global challenge right now. It's across the United States. It is not just about new migrants bringing measles to the city. And so our messaging had to be carefully tailored and driven by some of this sentiment analysis. Next slide. So I will conclude with part of telling the story is the counterfactual analysis with support from CDC and the modeling that we did to help us prepare. And this counterfactual is important because as we tell the stories of why a vaccine is important and how rapid response and having an infrastructure for public health departments to be able to respond in such a way is vital. This is, just summarizes some of the findings from the MMWR report we published with CDC. And overall, what we saw here is if we hadn't started the mass vaccination when we did, and there was no active case finding when we did, like within 24 hours, we will have had a 69-fold chance of an outbreak that was greater than 100 cases. And if we had delayed our response beyond March 8th, we will have extended the outbreak duration by 6 weeks if we hadn't started the mass vaccination and active case finding within 24 hours when we did. And had mass vaccination been delayed by 1 week, there will have been a 9-fold increase in the probability of an outbreak of over 100 cases over the scenario where mass vaccinations were deployed on March 8th. So together, these findings, I highlight the value of prompt mass vaccination within a context of a large pool of unvaccinated people, especially in congregate settings, and active case findings to reduce the size of the measles outbreak and the duration of the measles outbreak. So these are the different scenarios if we had started case scenarios and not case scenarios, and how the number of cases and the duration of the outbreak will have increased accordingly. Next slide. So we thank you for the opportunity to share this with you. Vaccines for adults continue to be a challenge. This is an $18 million cost in terms of the number of vaccines that was required. It maxed out all of our vaccine inventory, and being able to continue to vaccinate as thousands of new arrivals continue to arrive in Chicago is now a huge challenge. Without the opportunity to keep vaccinating people as they arrive and the resources to do so, there is a potential that other outbreaks or more outbreaks will continue to happen. So thank you all very much for the space and the attention.
Thank you, Dr. Ige. Next presenter is Dr. Frank Belmonte from Advocate Children's Hospital.
Thanks so much. So I am from one of the children's hospitals in Chicago that collaborated with Commissioner Ige in the vaccine effort. But we're going to talk to you. We got this high-level overview of what we dealt with in Chicago this spring. We're going to talk to you about one particular case of exposure and the number of resources that we need to mitigate further spread on the clinical side. So on the 8th of March, a 3-year-old child presented to our pediatric emergency department with upper respiratory tract symptoms, no rash at that time. Many kids were in the ER with those very same symptoms at that time of the year. It's very common. He actually tested positive for both adenovirus and COVID at that time by RT-PCR and was sent home with supportive care. He was well hydrated at the time. He did return to the ED 3 days later with a rash and increased lethargy. Vaccine records revealed that he had received his first measles vaccine at the age of 15 months, and he had no known exposures. This was not a child that was in one of the migrant shelters. He was admitted to a negative pressure room. I'm happy to say that our physicians recognized the typical measles rash, and they did admit him to negative pressure. On the 13th of the month, we got the confirmation that his measles PCR was positive. So the typical course for measles, the rash begins at the hairline, spreads to the rest of the body. The rash typically lasts for 7 days, but these children also come in initially with what look like a viral prodrome. So fever, cough, watery eyes, conjunctivitis. This typically resolves on day 3 of the rash. They can also get very sick. We get a lot of kids that will present that also have dehydration or other symptoms like ear infections. And that is the typical measles rash. Interestingly enough, most physicians don't know what that looks like anymore because we haven't seen it because of vaccines. So we had to do a lot of teaching to our younger physicians who had never seen a case. Measles is extremely contagious. It's probably one of the most contagious viruses that we know. Exposure in an airspace that's a closed airspace for 2 hours post that patient leaving that area. So you can imagine with a kid in a jammed, packed emergency room, we had lots of exposures from that initial day. So there's 3 parts to our intervention on the clinical side: determine who has been exposed, determine who needs post-exposure prophylaxis because you have a window of opportunity to deliver that, and then also limit future exposures and work with the local public health jurisdictions on that part of the process. So step 1, determine who had been exposed. We commenced our incident command structure. We were very familiar with this because this was how we did COVID. So we learned a lot. The health systems learned a ton from the pandemic. And I'm pleased to say we know what public health is now, which is great. Determine the patients and the teammates that were exposed to this infected patient or the airspace within that 2-hour window. And we had two potential exposure times. So the ED trip on the 8th and then the admission on the 11th. And then that time period where that child was at home, we had to determine that. And that's where we worked with the local public health department. The tricky part to measles is that the rash may not start for 5 to 6 days post the time that they're infectious. So during that time period, they could be exposing a lot of other people that are susceptible. And that's kind of the tricky part, is trying to figure out who these kids are. So the next step is, once we determined that we had some potential exposures, and it looks like my slide cut off a little bit there, we had to determine who needed post-exposure prophylaxis with either immunoglobulin or vaccination. And you can see the guidelines there based on age. We had on the first day 28 potential exposures, and then on the second ER visit, another 72 potential exposures of children, adults, and teammates that were exposed to this child. Well, we had, I think on the first day, we had 7 that required vaccination, another 6 that required immune globulin. And then the second time we had 8 children requiring MMR and 1 requiring immune globulin. All the patients were also required, anyone who was exposed, to be notified by certified letter. So we had to make sure that we worked with the Chicago Department of Public Health on that. So intramuscular IMIG is preferred for kids less than 12 months of age. We can use the IVIG for individuals greater than 12 months old, but supply chain is also an issue. So we had to actually get these meds shipped to us from one of our other hospitals in the system so that we could distribute them. We also had to have a plan for bringing those kids back so that we could give it to them safely and not expose other children, in the vicinity. And then if the IVIG or the IMIG is administered, quarantine needs to be extended from 21 to 28 days. And so all of those instructions had to be given to the families. So the next part is limiting future exposures. I can't emphasize enough that incident command structure is really important to this. You have to have all likely stakeholders: pharmacy, supply chain, lab, our public affairs and marketing team. And I'll talk to you a little bit about some of the efforts we did to do outreach after this exposure. We also had to develop and disseminate tools. We used a lot of tools from our local public health jurisdictions to give frontline clinicians real-time education on identifying measles cases, because many of them had not seen it in the past. Also, the testing guidelines are different depending on which public health jurisdiction the patient's originating from. We have the city of Chicago, we have Cook County, we have the state public health department as well. We were able to craft an outreach to patients eligible for the MMR vaccine. That was a big win in this. So we actually queried our electronic medical record looking for kids who were delayed, and we got notification out to those parents to get them in, saying that we were dealing with an exposure in the city, and that was very fruitful. People were able to make those appointments online and get their kids in. We also had to flag we use Epic as our EHR. We had to get a flag put in because anyone who was exposed, we wanted an urgent care that was going to see them, a primary care office that was going to see them, to see that in the banner at the top of the EHR so that they followed mitigation efforts for exposure in their office, and they got those kids back to a room right away. This is just an example of the flagging in the EHR. So it's a big orange flag at the top of those patients' charts that expired at the end of the 21-day window, but it really was a great way of notifying other folks on the team that this child had been exposed. And this was just the outreach, and we were able to get these out to several thousand patients. They were able to make appointments online to get the vaccine. This was actually a very helpful piece as well in mitigation. We also, as a health system, promote vaccination and certainly work with the Chicago Department of Public Health on that. We provided about 250 MMR vaccines to migrant children. We have 2 mobile vans. We were able to get out to O'Hare. We were able to get out to one of the migrant shelters in Chicago, of course, being coordinated by the Chicago Department of Public Health, and really helped in that effort. We also reviewed hundreds of vaccine records that we were able to gain, especially from the migrant children, and enter that into the LNA vaccine registry, iCare, which really helps to continue to follow those kids. Teamwork does make dream work. So again, during the pandemic, we learned that we can't do this in isolation. So the local, city, and state public health authorities were very important in the effort. We had a clear line of communication with them on a daily basis, and that collaboration really led to a more comprehensive and diligent response across the board. Can I play this? So this is a news clip, a local news clip on our patient. And I thought we would just end with this to show you the fear of these parents. I mean, many of them have never seen measles either. So it just gives you a little overview of what they were dealing with.
How her son was infected with measles. He doesn't attend CPS schools and has mostly been at home. But his experience with the virus is something she never wants to have to endure again. Jessica Coletti never thought it would happen to her family.
I feel like I've woken up in a different world.
Her 3-year-old son, Vincent, started feeling sick last Wednesday.
He was lethargic, not drinking, not eating. We were in the hospital on Friday, and they sent us home, told us it was COVID.
But days later, he was back in the hospital.
He woke up Monday morning, didn't talk, didn't move, and the rash started on his cheeks, on his face, and moved all the way down his body. I knew something was severely wrong with my child.
She says Vincent tested positive for measles and was the sickest she had ever seen him.
I honestly thought he was going to die in my arms. And I just kept telling him that mommy's getting help and you're going to be okay.
The CDC recommends that children get 2 doses of the MMR vaccine, the first at 12 to 15 months of age and the second between the ages of 4 and 6. Jessica says her son has received his first shot, but he isn't old enough yet to get the second one.
When kids have one vaccine in, we're talking about a 93% efficacy in protection against the measles. When they have 2 vaccines themselves, we go up to 95 to 97% efficacy. We have a lot of toddlers in this little age group where they might fall into this range where they don't have enough immunity built up.
Tonight, Vincent is starting to bounce back.
He seems much better. He's sitting next to me. He has chocolate on his face, but he is much better.
But now this family's concern is turning to their other child, who's already showing symptoms as well.
I never would have thought we would came back positive for measles. And now I'm just scared and concerned for my 10-month-old.
And we just heard actually from Jessica again, just within the last few hours here. And she does say that she's in the ER once again now with her 10-month-old daughter after she started to feel worse. So the entire family now's in quarantine for 21 days after what has been obviously an incredibly scary ordeal.
Spoiler alert, the younger sibling did not have measles, so that was good. That's the end of my presentation, so I'll take any questions. Thank you.
Thank you very much, Dr. Belmonte and Dr. Ige. Are there any questions or comments from members of the committee here or online? I just have to, give my anecdote. The first case of measles that I saw was in a fellow resident in 1992. So
I have to say I'm old enough that I have seen it. So yeah, but the young trainees that we have now have never seen it.
Oh. Right. Well, thank you all very much. Important presentation. Hopefully, please let us be beyond this surge of measles we saw earlier this year in the United States. All right, we have now reached time for our afternoon break. It is 3:05 Eastern Time. We're going to break until 3:15, at which time our panel will be breast cancer vaccine innovations in the works. Thank you for joining us for our June NVAC meeting.
Produced by the U.S. Department of Health and Human Services.